Hi, this is Jerry DiPiano, CEO of FemmePharma, and you are listening to or possibly watching the Love Mia Vita podcast. Today, my guest is Dr. Dana Shanis, and Dr. Shanis has been a person who has been involved with FemmePharma as a medical advisor, clinical advisor, and part of our scientific advisory board. She is a board-certified obstetrician gynecologist, a collaborating writer with the National Institutes of Health, and the owner of V Health and Wellness. Dr. Shanis received her medical degree from Temple University School of Medicine and completed her obstetrics and gynecology residency at Sinai Hospital of Baltimore. She attended fellowship at the National Institutes of Health, where she studied gynecologic care of cancer survivors and other medically complicated issues facing women. Since her fellowship, Dr. Shanis has remained involved in research, publishing, and presenting at meetings and conferences across the country. Over her years of practice, she's been recognized by numerous organizations for her compassionate care of patients. And Dana, we are so excited to have you as our guest on the Love Mia Vita podcast. And today, the topic that you're going to share with healthcare practitioners and women, if they happen to be tuning into this, is really the gynecologic care of the cancer survivor. And specifically for this podcast, we're focusing on the breast cancer survivor, although some of this information is applicable to women who are experiencing the effects of post-treatment for other gynecologic cancers. So let's start with the way we communicate to your patients. For those of you that are listening in that are healthcare practitioners, this is really a complicated issue, and certainly we all know that as professionals, you want to treat your patients with compassion. And you certainly are challenged because a lot of this information has never been shared with you in medical school or possibly even in a fellowship or residency program. So Dana, let's start off with even the terminology. Maybe you want to just kick off with your presentation. So Dr. Shannon has some slides that she's going to share with us.
Yeah, thank you so much for having me. This is a topic that is really near and dear to my heart, and so I'm really happy to be able to share this with you today. I'm going to share my screen. Okay, so let's jump right in and let's talk about what a cancer survivor is. So technically, a woman is a cancer survivor from the moment that she is diagnosed with cancer. And this is really important because I think that where we can have an impact on their well-being starts right at the beginning. We don't have to wait till they're done with their treatment. And for some, they won't be done with their treatment. For some, their cancer becomes a chronic illness that they're dealing with. So I think it's important from the moment of diagnosis that we think of them as a survivor and try to help them to live the best quality of life that they can. So there are a lot of cancer survivors in the U.S. today. I actually have updated data from this. As of 2022, there are 18.1 million cancer survivors in the U.S. And the most common type of cancer is breast cancer. This is just going to increase. With the better screening and treatments that we have, this number is going to go up and up. And it's projected by 2040 that there will be almost 30 million cancer survivors in the U.S. Women are more likely than men to become long-term survivors. And one of the things that I'm hoping to achieve by doing this is to help train people who may not have been trained to see cancer survivors, because there's a shortage of people who can actually comfortably treat these patients at this time. And as that number grows, the need will be even greater. So what I'm going to go over is the transition that happens when a person is diagnosed with cancer. And that includes the ongoing medical care that they're going to go through. And then I'm going to talk about the special populations, the breast cancer survivors, for the talk today, and then recommendations overall on how to improve the quality of life and factors, including sexual health. So becoming a cancer patient to a survivor, initially, the first thing that you're dealing with is treatment. And there's a lot of fear and anxiety that goes into that. I think it's also important to realize that when you're diagnosed with cancer, something that you have always taken for granted, that you're going to wake up the next morning, is suddenly not so clear. And that can have an impact on every aspect of your life. Everyone responds to things differently, but it is unusual that that does not cause some level of fear or anxiety of what the future will bring, and some questioning of what is really important in your day-to-day life. Once you're done the acute treatment, then there's an extended survival or possibly remission. And there's a huge amount of anxiety here as well. It's not the case that it's over and you can move past it and be the person you were before. There's always concern that the cancer will return or a new cancer will pop up. There also is often long-term toxicity from the cancer treatment. So it's not necessarily that you feel back to physical health either. And then permanent survival, or when you're cured, is actually not very common. We really consider it extended survival, but the risk of recurrence goes down over time for many patients. And then they are still dealing with the long-term and late effects of both the psychological issues and the physical treatments. There are a lot of complicating factors. Some patients assume the sick role and have changes in the relationship, some for the better, some for the worse. That's both with a partner and family and friends, and also with yourself. It can put some challenges to your ideas of faith as well. We see patients who were very religious previously who have trouble with that moving forward after they become a cancer survivor. And unfortunately, the way that the US is now, the cost of healthcare, there is a huge burden of financial and employment issues. A lot of jobs will not just, let you, despite the protections that are there, many people are not able to return to their jobs in a reasonable amount of time and face financial difficulties. So in terms of the ongoing medical care, I think it's really important, if you're going to be seeing patients who are cancer survivors, to understand what they are going through. Even if you are not particularly responsible for this, it can help inform how you approach the burden that they are dealing with. And so, as I mentioned before, there will be continued surveillance for a recurrence of the primary cancer. And this varies on the level of screening, but almost all patients will continue to go through surveillance for recurrences. Cancer also, and its treatment, is also a risk factor for new cancers. So that is something that is really important, and we recommend that that all cancer survivors are up on their other screening tests, like a pap smear for cervical cancer or colonoscopy for colon cancer. The physical effects of treatment, it may affect bone density. It may affect, depending on treatments, lungs, skin, vaginal tissue. So this is something that will need to be treated ongoing. And then the psychosocial consequences, which are huge, is something that needs to be continually addressed. That's one thing that's in the over a decade that I have been working in this area and presenting in this area and talking with oncologists. That's something that is becoming more and more apparent, even with the diagnosis and the basic treatment, that the rate of mood disorders is so high that many cancer protocols now include antidepressants, which is a really nice change. So, an antidepressant doesn't solve the problem, but it's addressing the effects that this has psychologically and neurotransmitter-wise on our well-being. And then maintaining wellness is also really important. And I think this is something also that has been growing in awareness. Things like our diet, exercise can have a really big impact, not just on our quality of life, but actually on the risk of recurrence and actual health outcomes as well. So it's something that we need to empower patients to consider in their day-to-day life. And I'll go over with a bit about that, what we recommend and what the data on that is in a couple minutes. All right. So one of the really important ways that cancer treatment affects quality of life in general, and specifically sexual health as well, is ovarian failure. And that's something that can be transient or it can be permanent. And so we do see it's not uncommon for patients who are undergoing cancer treatment to have a temporary amenorrhea, a temporary stopping of cycles. That also relates to fertility as well. So, I put this first point in here that when somebody is diagnosed with cancer, you may still be fertile even at the beginning of the cancer treatments before that amenorrhea may set in, which it does not for everyone. So it is really important to not assume that your patients are not having sex and to discuss contraception with them. This can be difficult when they're dealing with such an emotional topic, but an unplanned pregnancy during all of this will greatly complicate things moving forward. So contraception is valuable to discuss. So the acute ovarian failure can happen during or after the treatment. And as I said, it can be transient or it can be permanent. What we do see is an increased risk of premature ovarian failure, which is going into menopause prior to the age of 40 in patients who have undergone cancer treatment. So this is something that should be assessed and patients should be counseled for. There is testing that can be done to look for ovarian function, which we can discuss more in the future if there are questions. And all abnormal uterine bleeding should be evaluated because that can be a sign of polyps or hyperplasia or abnormal growth in the uterine lining. It should not be assumed that that is normal with your cancer treatment. All right, so the type of treatment that you go through is related to the risk of ovarian failure. So chemotherapy, the type of chemotherapy that you have makes a difference. If it's high dose, you have a long duration, or you're older, the risk of permanent ovarian failure is higher. So as I said in the previous slide, a majority of patients may have amenorrhea or a lack of periods from the chemotherapy, but most by standard regimens will resume. But older age, the risk goes up. And with the other factors that we talked about here, the risk goes up. All right. And so what are the consequences of that ovarian failure? Being rapidly put into menopause is typically a much more severe form than when it happens through the natural process over time. So the menopausal symptoms can actually affect every tissue in the body. The most common that we see are hot flashes, night sweats, and vaginal dryness. But really, any hormonal symptom that you can think of, somebody has had it from menopause. So it's important to know that and ask about these other issues, as well as hot flashes and vaginal dryness. Infertility, certainly once you're in ovarian failure, that's an issue. And for some of our young survivors, that is a huge source of anxiety and disappointment. Luckily, oncologists are getting better at discussing fertility before treatment. So that is not a conversation that is as taboo as it used to be. But there still can be a lot of emotion related to that loss of fertility. So it's important to recognize that and be sensitive to that. Sexual dysfunction, which is really important, and I'll talk about individually, can happen not only from the vaginal dryness, but it can affect all stages of the sexual cycle. So there can be decreased libido, issues with arousal, difficulty with orgasm, as well as pain during intercourse from dryness and also from spasm of the pelvic floor and things like that. There are some tests that we can use to test for that. One thing that I do want to point out is AMH is a very good predictor in cancer patients of return of cycles. So determining whether it's an acute versus permanent amenorrhea or menopause. That is something that's not as accurate for non-cancer patients. So just something interesting to know. But typically this diagnosis is done clinically by their symptoms and looking at their treatment history. All right, so let's jump into the psychological issues. It's really hard to simplify the range of psychological issues that really anybody experiences, let alone somebody who is undergoing the trauma of a cancer diagnosis and treatment. So one thing that I think is really important to know is that no two people are going to process this the same way. So I'm going to go over some of the things, the challenges that people face, but do not be surprised if you have some patients who come in, feeling completely different and feeling, it really is an individual experience that no two people experience the same way. So psychologically, pain and fatigue are common, and that affects kind of the desire to do lots of things. So one of the issues that we see is a loss of enjoyment in things that were previously enjoyed before. And that can be related to depression, but that can also be related to pain and fatigue from the stress or the cancer treatments themselves. There's at least a 2 to 3 times rate of depression, anxiety, and insomnia in cancer survivors. I think that's actually underestimated. I think that a lot of patients kind of just assume it's normal to feel that way and don't really report the challenges that they're experiencing. So in my experience, it is much higher than that in reality, the rates of depression. Many patients experience PTSD from some portion of this. And I think that's really, really important. As a medical provider, one of the really common forms of PTSD that I see is medical trauma. It will make these patients who have undergone this need to build more trust with you and possibly take longer to be treated and to accept your care or even to come in at all. Recognizing that and treating patients in a trauma-informed way is really, really important to be able to best care for these patients. And, I also recommend, whether they clearly have PTSD or not, that all of these patients talk to either a support group, a psychologist, a therapist, a social worker, somebody about what they're going through at some point in their survivorship. Some people are ready for that early, others need a little bit more time till they're ready to unpack all of that. Antidepressant use is really growing, which is great. But that comes with some side effects as well, which I'll touch on during the discussing sexual health, that it's a double-edged sword. It may help with mood, but there are some direct side effects of that as well that may affect other aspects of their life. And then early menopause can bring insomnia, which can affect mood, irritability, depression, and decreased libido in itself as well. All right, so let's talk about sexual health, excuse me. It is important to quality of life. There are studies, there are actually a lot of studies looking at the relationship of sexual health to overall health, and almost all of them correlate good sexual health to good quality of life measures in patients. It also correlates to lower medical issues. So all of the kind of other medical things that can go along with getting older in general, but also in cancer survivors, are improved when there's a good quality of sexual health. So that's why it's important. Now, depending on which study you look at, 30 to 100% of cancer survivors report dysfunction. I would say, in my experience, it's 80, 90% that report dysfunction. And I think the important factors to think about here, when you look at sexual dysfunction in cancer survivors, is one, that dysfunction is considered only when it causes distress to a patient. So some patients lose their libido, or do not or are not able to orgasm, but they are not bothered by it in the moment. That is not technically dysfunction. It is important to continually check in with these patients, because they may not be at a point where they want to focus on that aspect of their sexuality at the moment, and that's okay, and we don't need to push that. But counseling that if it becomes something that causes them distress, that there are things that we can do and that they should talk about, is often the first step for them kind of to process what it is doing to them emotionally. So patients will tell me they don't really mind, and then I'll get a call a week later saying, well, actually, I would really like to be able to have sex with my husband. And so I think planting that seed of what is normal versus dysfunction is very valuable. What is frustrating about sexual dysfunction in cancer survivors is even when other measures of their well-being, so let's say they're off their treatments, they really, by all accounts, are feeling pretty good, the sexual dysfunction tends to remain more longer than you would expect, given that everything is going back to normal. And they don't, and this still to this day, oncologists themselves don't want to talk about sexual health. They have a lot to go over. Many of them were not trained on this. It's also a conversation that takes a lot of time. Somebody is not going to open up about all of their sexuality and their sexual experiences to somebody who has their hand on the doorknob to walk out the door, or doesn't feel comfortable listening or asking questions to it. So I actually, when I talk to oncologists, I tell them I don't think it is your job to talk about this. Maybe saying a lot of patients experience this, if you are, there are resources, could be helpful. But this is something that I actually reach out a lot of times to the nurse navigators or the mid-levels that are working with the oncologist to be the ones to bring up this topic. So, if you are seeing a patient, you should not assume that their oncologist has mentioned any of these issues to them, but hopefully somebody in the team has. I believe that discussing it early can mitigate the risk. The data is kind of mixed on that, but I think that's because of the nature of how complex sexuality is, and our measures are really not perfect at assessing that. So I've seen in my experience as an OBGYN, I have been there when patients have been diagnosed, and I've told them right from the bat, this is some of the experience that people go through. And I find that they come to me earlier to start working on the issues that affect them. And so I believe that that does decrease the likelihood and the severity of their sexual dysfunction. Now, like with every person, sexual health is really complex and multifactorial. There are there's a whole physiological cycle and system that has to work that is related to lots of neurotransmitters, lots of blood flow, lots of physiological factors, but also there's a huge psychological component. And that is both an interrelational with their spouse, with their partner, with who they are dating, with who they are deciding to be sexual with, but also within our own identity. So how we feel, our self-esteem, our attractiveness, all of this greatly affects the sexual cycle as well, and kind of muddies the waters of which part of the sexual cycle is really suffering. So I find this picture to be really, really powerful, in that I think that this woman is beautiful still. But when you look at these effects that have happened from her cancer treatment, it would be understandable how this would change not only how she feels about herself, but how she experiences sexual feelings and the sexual relationship. So I think it's really, really important to recognize that these alterations may change who we are. And the breasts are a very a very feminine feature that a lot of us associate with being a woman. And with the removal of that, that can deal a huge blow to our sense of femininity, which is for many is an important part of their sexuality. What we also find is even in those patients that have worked past or accept and love their body as it is now, partners are often hesitant. Not necessarily that they no longer find the person attractive, although that has happened at times too, and that's a fear that patients go through a lot. But they also have just gone through watching their loved one be in the sick role, and may not know if they are capable of having sexual activity or if they want to have sexual activity. And a lot of times they feel bad communicating that. So I've also seen patients who are like, I'm ready to go. I want to have sex. I feel good. I'm alive. This is something that I would add to my well-being. And the partner is just saying, well, I'm not ready for that. This is where the communication is really, really important. And I think that, with any relationship, communication is important. But I think that how partners respond to cancer is very complex and often needs to be unpacked with a psychologist or a therapist or with open dialogue with the patient. Now, one thing that I do see a lot, I have a lot of patients who don't have a current long-term partner and are worried, how am I going to date? How am I going to develop intimacy with a new partner? And I think this is a really big challenge. In general, where I tell patients always to start is start with themselves, with their confidence, what they want, and share things when they feel ready to share them. But I think that there are people better qualified to talk about this in more detail. The psychologist, I do often refer these patients to kind of talk through how they are going to approach dating in this new body and new mindset of theirs, where there may be challenges to what is perceived as normal sexual activity. Okay. So this is reviewing how the different types of treatments may affect sexual dysfunction. One thing I do want to point out that with surgery, there can be a loss of the nipple, and many patients find that prior to their treatment, nipple stimulation was an important part of arousal or reaching orgasm. And so that can really cause an issue in relearning what now feels good when you lose that source of arousal and pleasure. All right. So how do we address it with a patient? The first thing I think is to reassure that having sexual activity is safe and it is reasonable to consider it if she is interested. If she is not interested, I think it's equally important to validate that it is okay to not be interested. Sexual activity and sexual desire and function varies over everybody's lifetime. There are times where we are more focused on that and times when we are less focused. This is not necessarily a problem unless it causes you distress. So if the patient says, you know what, I don't want to have sex now, and that should be validated as well. And I think, Jerry, something I've told you many times is that I have written prescriptions for patients to not have any vaginal penetration, and vice versa. I've written prescriptions for patients to have sex so that they can show their partner that it is safe. Their doctor says that it's important for them, and they don't have to be afraid of that. Now, one thing I do want to say about that is that there are some chemotherapy agents that are present in vaginal secretions. So as you're, telling them that it's safe, you do want to make sure that they are not currently taking a chemotherapy agent that can be exposed to their partner. So that's where that oncology plan can be helpful. But if they're not actively undergoing any chemotherapy treatment, there really is no concern in terms of their health safety of resuming sex. I think it is important in reassuring them that it is safe and can be important, that they may also have trouble, that it may not feel like it did before, that they may have dryness, they may have pain, they may have difficulty with orgasm, and that all of these things are common, but not necessarily normal or what they have to accept. So I think putting the seed out there that what the difficulties are, and say, if you experience them, if as a provider, you don't feel comfortable dealing with that, find somebody like me, or, somebody who focuses on sexual health, to say, if you experience any of these issues, here's a person that you can see that deals with this. And that can be really, really validating. And then I think, with any medical issue, especially in this day and age, we ask them, what are you concerned about? And, you'll get a whole array, and I'm actually tearing up a little bit at thinking of the responses that I hear patients respond about, that often their concerns have nothing to do with sexual dysfunction, or it has to do with their relationship or their partner, or they're not feeling like a woman, or whatever it might be. Letting them be candid about that is really the first step in addressing these issues. So, I put it under sexual dysfunction, but I think this is really for wellness and psychological well-being as well. To just ask them, what are you concerned about? And then treat. So I think that almost all people can benefit from individual or couples counseling. There are ASEC certified sex therapists, and around the country, there are various ones who are trained in cancer survivor care. So if there's one in your area, I would highly recommend getting the referral to them ready on a regular basis, because I think that that even when there are physical issues, talking through the psychological issue and relationship issues are really, really important. You want to treat menopausal symptoms. If they are having insomnia, that really is going to put a damper on their libido. So you want to make sure that we're optimizing how they feel in general. Lubricants and moisturizers are really, really valuable. And those are something that I recommend that patients try first. Vaginal estrogen is not necessarily my go-to in breast cancer patients unless they have failed moisturizers and lubricants. If they're only noticing dryness during penetration, then a good lubricant may be enough. But a lot of patients feel this dryness at other times. And so the moisturizers really would be good for that. I think that pelvic floor PT is also something that is very helpful. What we find in our cancer patients is that once a patient has pain with sex, whether that be due to dryness or other reasons that you can have pain with sex, almost always there is a compensatory spasm of the pelvic floor muscles. And this is a normal physiologic response to pain that muscles do anywhere in our body. But in this case, that pelvic floor spasm is not protective for preventing pain in the future. It actually increases the pain. So pain with sex becomes a cyclical process that once you have pain, then your body creates spasm, which creates more pain. So pelvic floor PT is a very valuable treatment for patients, cancer survivors who are experiencing sexual dysfunction. All right, so let's talk about maintaining wellness. So weight control, diet, exercise, a healthy lifestyle, which I know we recommend for all patients always, and is really hard to get patients to do. But when I present it to cancer survivors that it may improve your prognosis, your symptoms, and recurrence, I do find that they're more likely to consider these factors. I also think with all of the information that is out there now, patients are more savvy that nutrients and things like that and inflammation play a role in our health overall. So this is something that is becoming easier and easier to counsel patients on. Now, exercise, and this is regardless of the reason that a patient is coming to see me, I tell them that exercise is pretty much good for everything. So it can help with fatigue, the psychological distress, and quality of life. And even in small amounts may benefit quality of life for patients. There's even data that it may improve outcomes and recurrence risk as well. So exercise should be encouraged. For many patients, especially if they underwent surgery, it may be beneficial for them to start with supervised activity and to make sure that they don't then injure themselves. And the guidelines for cancer survivors is no different than the standard ACS guidelines. All right, so smoking cessation is another kind of no-brainer, but what we find is in cancer patients, the tobacco use is actually the same as the general population. Younger cancer survivors are more likely to continue smoking. I think that part of this is a coping mechanism, or that they are, self-treating some of the issues. So I think it's really important to address smoking with all your patients, but especially in your cancer survivors, and look for underlying pathology, underlying depression, anxiety, or things like that they may be self-medicating. In general, most effective is a combination of counseling with medication. So if you feel comfortable, or you should feel comfortable bringing that up, but it's really important in the cancer survivors to try to discuss that. What is really interesting is alcohol and drug abuse is actually slightly lower in cancer survivors than the general population. I'm not so sure that I've seen that in my practice. I think that maybe it's underreported in many studies, but there isn't really data that it is a much larger issue. But same with tobacco, that PTSD or psychological issues, many patients may self-medicate. So it's something that you still want to ask about, and not assume just because they're a cancer survivor that they do not have a substance abuse issue. Now, one interesting thing here, and I've seen this with patients, I've seen this actually in my own family, that siblings of cancer survivors actually have really high rates of depression and mood disorders and substance abuse. So this is something, you may or may not feel that you get to know the patients, well enough, their family well enough to discuss this. But it is something that has been documented and I've seen. Just like a cancer diagnosis puts a strain on a relationship, also family members may experience that strain. So that's just an interesting thing to keep in mind. After treatment, encourage appropriate cancer screening moving forward, assess for ovarian function, ask about anxiety, depression, and sexual dysfunction. If you don't ask, they may not tell you. And so it's important to ask. Reinforce the importance of exercise and maintaining a healthy weight, and as well as diet. Thank you.
Dana, that was a wonderful presentation. And I hope that anyone that's tuning in, whether you are a healthcare professional or you are a layperson that has tuned in to learn more about gynecologic care of the cancer survivor, that you've gathered some real pearls of wisdom and ways in which you can help your survivor and thriver to navigate through this, the post-cancer diagnosis. And obviously there are still many questions that remain, and we hope to have you come back and address some of the basics.
Yeah, I would love that.
So we expect to see Dr. Shanis once again, as she has this very distinguished background in obstetrics and gynecology, and in particular in survivorship and working with that population. And I know that at FemmePharma, we have interviewed a number of women who are survivors of various cancers, in particular breast cancer. And we're very excited about having the opportunity to provide high quality, well-vetted information, both to the survivor because they are seeking this information, and also to their healthcare practitioners who are very compassionate, but perhaps haven't been armed with the same level of knowledge and experience that Dr. Shanis has had in her career. So Dr. Shanis, Dana Shanis, thank you so much for being a guest on the Love Mia Vita podcast. Be well, continue to do your good work. We love that you are close by. We're both in Philadelphia, Pennsylvania. So I have the pleasure of occasionally seeing Dana face to face. And if
Yes.
you happen to be in the area, understand that V Health and Wellness is Dr. Shanis's practice. And if you are a clinician, obviously you can reach out to her. And if you are a woman who is listening in and you're seeking someone who is compassionate and does understand your journey, then Dr. Shanis is your go-to person. So Dana,
And
once again, thank you.
oh, it's my pleasure. And I just want to say one more thing, that if you are located not near here, but are having trouble finding resources, feel free to reach out to me, and I can try to find somebody within our network that that may be nearby. I also am happy to talk to your healthcare provider directly if they don't feel comfortable treating you, because there aren't enough of us around. I'm happy to help whenever I can.
Thanks, Dana. That was great advice. And once again, thank you all for listening to or viewing the Love Mia Vita podcast. Thanks again, Dana. Be well.